Hello and welcome back to CCRN Review Respiratory Part 2. Let's take a look at some of the additional problems here that the AACN wants us to know about. So first of all is chronic ventilatory failure. And we have more patients who end up being on a ventilator who we can't get off. So, those patients who have chronic on acute on chronic COPD, pulmonary edema, airway obstructions, atelectasis, pneumonia. Those kind of patients, oftentimes we find that we have difficulty weaning them from the ventilator. So the first thing to understand about mechanical ventilation is that we're using it as a temporary treatment. We're expecting that we're going to get this patient over the hump, give them the antibiotics, give them the medication, whatever it is they need, and get them over the hump and then wean them off of that mechanical ventilation. We're never expecting that we're putting somebody on a ventilator with the idea of keeping them on the ventilator forever. That's not the case with mechanical ventilation. So we always hope that we're going to get the patient off. But some of these things happen, and then we end up not being able to get our patient off the ventilator. This picture that you have here showing the thoracic cavity gives you some idea of some of the different components that might interfere with how well the patient is able to breathe on their own. The rib cage, the intercostal muscles, the diaphragm, the heart, the vasculature, all those things could have an effect on our patient's breathing and whether or not they're able to get off of the ventilator. Neurologically, there's a number of things that would keep our patient on a ventilator: Guillain-Barré syndrome, botulism, myasthenia gravis. So you can see there's a lot of different types of neurologic problems that will make a patient dependent upon a ventilator. Malnutrition plays a part here. If our patient is malnourished, they're not going to have an adequate albumin level, and a low albumin level is associated with not being able to wean from the ventilator. Chronic hypoxemia, decreased cardiac output, and electrolyte abnormalities. Now, in many cases, the decreased cardiac output could be the result of mechanical ventilation. On the other hand, if the patient has a cardiac problem and we're trying to wean mechanical ventilation off, we may find that the patient ends up having decreased cardiac output as a result of our weaning process. Then we need to go back and look at the patient's fluid status. What happens during weaning is that we have decreases in our intrathoracic pressure, which allows more fluid to come back up toward the heart, maybe overwhelming the heart and decreasing cardiac output. Over on the right-hand side, you see the weaning parameters. So these are some of the things we look at. We look at some objective measures as far as the numbers on the ventilator, the patient's airway pressures, etc., and their tidal volumes. And we look for adequate oxygenation. Are they able to adequately oxygenate when we decrease the amount of FiO2? And then there's our subjective assessment too. So we're going to be subjectively looking at the patient and making an assessment whether or not they're struggling to breathe when we start to decrease their ventilatory support. Symptom-wise, we would expect to see that there's an imbalance between our CO2 production and excretion. As our CO2 levels rise, the patient will develop dyspnea and tachypnea, tachycardia, accessory muscle use, and a change in mental status. We anticipate seeing some changes in the blood gas. CO2 levels are going to start to rise. O2 levels may start to fall. Keep in mind that CO2 is a function of ventilation. O2 is a function of perfusion. Now, obviously, we have to have ventilation in order to maintain perfusion. If we're not getting oxygen down to the alveolus, then we're not going to have perfusion occurring. Our tidal volume, so we can be looking at tidal volumes and vital capacity, the negative inspiratory force. Those things are also some variables that we look at to help us to decide whether or not this patient is going to be able to wean from the ventilator. So treatment is, well, we could maybe switch the patient over to a non-invasive positive pressure ventilation, such as BiPAP in the picture here. Intubation and mechanical ventilation, so just re-intubating the patient. We really don't like to do that if we can avoid it, but we may have to if the patient fails their trial of spontaneous breathing. Goals is to optimize our respiratory function, slowly wean ventilation, so we can rebuild that respiratory musculature. It only takes about 3 days for the patient's respiratory musculature to become severely weak as a result of being on mechanical ventilation. So certainly we want them to be doing as much of their own work as possible so that they're not ending up having weak thoracic musculature. COPD is another one of our respiratory problems. More than 16 million Americans are affected to some degree. So very common. Second largest financial impact on the Social Security disability system, second only to heart disease. So that's a pretty important piece of information showing how prevalent COPD is. Keep in mind that many of your patients who have COPD may or may not have been diagnosed. So the patient, unless they've gotten to the point where they needed hospitalization, they may not have been diagnosed yet and come into the hospital having some respiratory issues with this underlying COPD. Fourth leading cause of death, and 45% have restrictions on their activity level. Now again, if people are developing symptoms as they age, they may think that this restriction on their activity level is just part of the aging process. Etiology, well, most of it is due to cigarette smoking. However, there are other ways that patients develop COPD. So when you look at our patient population and you got 100 people, 100 COPDers in a room, and say, well, 80% of them there, they have COPD as a result of smoking. But there's the other 20% of the other 20 people in that room are going to have COPD from another etiology. So maybe air pollution, if they live in a city that has a lot of air pollution. Their occupation, if they're a firefighter or a coal miner, where they may be inhaling dust or they may be inhaling smoke that could be damaging to the lung. There's a questionable genetic link to COPD. We all know people who've smoked 2 packs of cigarettes a day for 50 years and they're fine and they don't have any respiratory problems at all. So, there is some other component here that is predisposing people to developing COPD. And we don't quite know exactly what that is, but there has been some research looking at that. Hyperreactive airways, and then the alpha-1 antitrypsin deficiency. So alpha-1 antitrypsin is a enzyme in the body that helps to protect the body from its own inflammatory response. Now, when you breathe in, and you breathe in some pollution or something like that, and it gets into your lungs, there is an inflammatory response that will occur in the lung to get rid of that stuff. So it's going to eat it up and get rid of it, and then you don't have any problems with that. But in some patients, they have an alpha-1 antitrypsin deficiency, and what that is that we don't have enough of this enzyme, so this inflammatory response that occurs in the lung as a result of maybe pollution or something like that is not able to stop. We don't have the alpha-1 antitrypsin protecting the normal tissue around that, whatever environmental piece that came into the lung. And so we're not only damaging the invader, but we're also damaging some of the healthy lung. So when you take a look at COPD, we have this process that's occurring in the lung. So here's a healthy lung lumen. So this is the airways here. We're looking at the airways, and there's a little bit of muscle around the trachea there and some smooth muscle, etc. But you see how big that lumen is. Now what happens in COPD is the smooth muscle starts to become thickened. It's irritated, and the inflammation is causing that muscle to clamp down. It's causing some bronchoconstriction. And over time, that constant stimulus of bronchoconstriction, or the muscle contraction, is going to cause that smooth muscle to start to thicken. So we get a narrowed lumen to the airway. In addition, at the same time, this patient is also producing secretions. So we have 2 components that are happening here in COPD. This is what we were just looking at a moment ago, is we have emphysema, which is the chronic destruction of lung tissue, and at the same time we also have chronic bronchitis, which is the production of secretions. So we have the production of sputum and we have the breakdown of the lung. Now, you may find that you see patients who have one or the other diagnosis. So they have chronic bronchitis, they have emphysema, or maybe they were diagnosed with asthma. And then those things typically end up having the same etiology or the same results at the end. So in other words, patients who are diagnosed with emphysema also have a component of chronic bronchitis. Patients who are diagnosed with chronic bronchitis also have a component of emphysema. So here's what we were just talking about here. So the emphysema part is the enlargement of the airways with the destruction. So here you see this in the bottom. Here we have the normal healthy alveolus on the left, on the right, the one that has been damaged by emphysema. And then chronic bronchitis, there's actually a diagnostic criteria for that, which is the patient has a productive cough for more than 3 months in a row in 2 consecutive years. So symptom-wise, we anticipate seeing some changes in the pulmonary function tests. They're going to do pulmonary function tests on these patients, and we expect to see some differences in their vital capacity, their expiratory reserve, etc. Hypercapnia may be possible. Hypoxemia, so that may be a possibility. We want to find out where that patient lives. You've all heard that, right? Where that patient lives with their CO2, because we don't necessarily want to blow that CO2 down. If we do, then when the patient weans, we're going to have to let that CO2 go back up again without the patient going into respiratory distress. Dyspnea, fatigue, productive cough. Again, remember that this is going to be common to both chronic bronchitis and emphysema. Changes in the amount or the color of the sputum. That's one of the first signs maybe that this COPDer will see that they're having some kind of infection or some kind of a problem. Wheezing, paradoxical respirations, change in mental status. So all of those things are possibilities. Criteria for ICU admission. So one of the things we need to know about this COPDer is how sick are they? Do they really need to go to the ICU, or can they just go to the floor? So we're going to look for respiratory muscle fatigue. That's going to be our key sign. Need for ventilatory assistance, refractory hypoxemia, start them on oxygen, need more oxygen. Well, what that's telling us is that even as we're giving this patient oxygen, their lungs are getting worse. Respiratory acidosis, and then cardiovascular instability is going to be the end result. So we want to catch this earlier when we're way up here in this spot where we have hypoxemia and respiratory muscle fatigue before we get down to acidosis and cardiovascular instability. So our pulmonary care for our COPDer is bronchodilators, anticholinergics. Okay, so these are both medications to help open up those airways. So again, looking at this airway here, we have an airway that is not only having hypertrophy of the musculature, but we also have all the secretions that are in the airway too, further blocking the airway. Aminophylline is a medication that was used for years as a bronchodilator. There is some question about whether or not it's effective, but aminophylline is a possibility. We still see it used in kids. Steroids. So steroids are going to help tomorrow. Bronchodilators help today. So that's, steroids are going to decrease the inflammation, and therefore, by decreasing the inflammation, then we'll start to open up the airways. Antipyretics, oxygen, airway patency, and assisted ventilation. Again, notice here I said oxygen. We got a COPD, and we're going to give them oxygen. Ooh, we don't do that, right? Well, we want to maintain oxygenation in this patient. Saying that a patient lives at a pulse ox or an oxygen saturation of 85% is probably not very accurate. So we don't want people living at an oxygen saturation of 85% because that means they're not saturating and they're not getting enough oxygen to the tissues. So we need to increase that oxygen and keep the patient oxygenating. So we are going to use oxygen even in our COPDers with the understanding that it may be difficult to get them off the oxygen, but that we need to maintain enough oxygenation to the brain. The idea that patients are going to stop breathing if we give them oxygen has been disproved a number of years ago. A number of studies were done looking at whether or not giving COPDers oxygen actually caused them to stop breathing. And what they found, in fact, was no. Even if we put our patient on a 100% non-rebreather mask, it did not cause that problem. So our goals are to prevent disease progression, relieve the symptoms, improve our exercise tolerance. We want to get this person moving better than they were before, or at least as well as they were moving before. So that is going to be our goal here. We're looking past just opening airways and just oxygenating, and we're saying, how can we not only treat this, but let's move past this and get to a point where the patient is healthier and they don't return with the same problem. Pneumothorax is another of our respiratory conditions here. Pneumothorax, we're going to talk about a variety of different ones here, but what's happening is that we get gas into the pleural space. Now, think about the lungs and think about the anatomy of the thorax. So what we have going on here is we have the chest wall, and in the chest we have the lungs. Now, the lungs are like a balloon. Think about them as like a balloon. That's a pretty good representation of our lung. In a normal state, a balloon is deflated, and then we have to blow it up to inflate it. The same thing is true with the lung. In a normal state, the lung is deflated. If you've ever watched a patient who's had cardiac surgery or who's had a thoracotomy for some reason, you'll notice that the lungs will collapse when we open up the chest wall. And that's because they need to have negative pressure or a vacuum in that pleural space that pulls them open from the outside. So what we've lost here is we've lost that vacuum in the pleural space. So that's what that's showing here. You see the lung on the right side is considerably smaller than the lung on the left because it is collapsed. A pneumothorax means we have air in the lung. Typically, air is going to go by gravity up to the top, whereas fluid goes down to the bottom. So if we're talking about our patients who have a hemothorax or a pleural effusion, we'd expect to see the fluid in the bottom part of the lung rather than the top. And if we're looking for a pneumothorax, we'd expect to see it up in the top. A spontaneous pneumothorax is a pneumothorax that happens, as the name implies, without any injury or any trauma. Oftentimes this happens to young people, maybe somebody who's in their 20s. Okay, so it happens to young people, and it just happens out of the blue. We were taking care of a patient, an 18-year-old girl who was just sitting on her couch and she's watching TV, and suddenly she starts developing chest pain and shortness of breath and doesn't know why. Well, we find out that she's got a spontaneous pneumothorax. A spontaneous pneumothorax usually occurs because the patient has a bleb, or an outpouching on the outside of the lung, and that thing bursts and allows air to get into the pleural space. Those blebs oftentimes are from weak spots. So they're weak spots on the lung, and those weak spots can, in fact, cause another bleb or another situation where we have a spontaneous pneumothorax sometime in the future. So we do have to be careful with these when the patient goes home. We want them to know that there is a possibility this could happen again, so get back to the hospital quickly. If we have somebody who has recurrent spontaneous pneumothoraces, what we'll do is we'll try to seal that lung to the chest wall. And one way they do that is by injecting talc. Traumatic pneumothorax, iatrogenic pneumothorax, that's the ones we cause. Tension pneumothorax. So this is a little different than the other types. The other types are just talking about the etiology. And a tension pneumothorax is a little different, though, because what we have is we have a one-way valve that is allowing air into the pleural space but not back out again. So if air is coming in and not going back out, that means that eventually we're not only going to have a collapsed lung on the right, but we're going to have so much pressure in that pleural space that we're going to start compressing the mediastinum and the left lung as well. So what you see is a patient with respiratory distress who then develops hemodynamic collapse. An open pneumothorax means that instead of having a hole in the lung, we have a hole to the outside, stab wound, gunshot wound, etc. Other times we could develop a pneumothorax is with a patient who has mediastinal drainage after a CABG. So there can be air that's formed in the mediastinal space, or we can actually nick the pleural space when they're doing the surgery. Pleural effusion is another possibility, and again, that's fluid that is collecting in the base of the pleural space. So our nursing interventions for this patient is that the patient needs to have a chest tube. We put a chest tube, look at the picture on the right here, and you can see there's a couple chest tubes here in the pleural space. So just indicating where we might put chest tubes if we have a hemothorax or pleural effusion, probably the one on the bottom, and if we have a pneumothorax, probably the one on the top. So the chest tube goes in between the chest wall and the visceral pleura, and the idea being that it's just going to apply some suction there, pull out the fluid or the air, and re-expand that lung. What we can do during the placement of that chest tube is to make sure that the patient has adequate analgesia. These things hurt. We want to make sure that there's sterile technique. It's sutured in place to prevent dislodgement. It's attached to a drainage system of some sort. Now, when you attach this to your drainage system, you now have a one-way valve, and it will start to pull the air out of that pleural space. However, if we want to pull the air out quicker, then we hook it up to suction. But even without suction, it's going to continue to do its job. It just does it slower because it doesn't have the benefit of the suction. We want to put a sterile occlusive dressing over top of that site where the chest tube is going in so that we don't get air from outside going in, following the tube and getting in there. And confirm placement, and a chest drainage system would be attached. So this is the components of a chest drainage system, and on the right side it has it broken down into color-coded areas. So if you think about those same areas on the picture on the left, you'll see that over on the right-hand side we have our collection chamber in yellow. In the middle we have that blue section, that's the water seal, and over on the left-hand side we have our suction control. Now, in some systems, instead of having this water-filled suction control and the actual water that's in our water seal, we'll actually have this done mechanically instead. So in some of these systems, you may see a little dial up there to dial in the amount of suction that you want, and there could be a built-in water seal. What the water seal does is it's a one-way valve. It allows air to go out, but not back in. So if air is coming from the patient, it's going to go through the collection chamber, through the water seal, and bubble out. The amount of suction that is applied to this whole system is controlled by the area in the green. We fill that area up with water. Okay, so the column of water is deciding how much suction goes to the patient. We hook that up to suction, and you turn your suction up just enough that there is gentle bubbling in that suction control. The reason for that is that if you turn it way up, you crank it up to maybe 100 or something more than that, what's going to happen is that you're going to bubble so much in that suction control that you're just going to evaporate away the suction control. And it doesn't make any difference how high that is up on the wall, so long as it's over 20. But if you put it up to 100 or 200, all you're going to do is bubble that suction control more, and you're not going to get any more suction to the patient. It's not going to work any better. So some complications, we want to avoid stripping the tubing. One thing that happens a lot of times is that we may get some blood in the tubing, and we think that blood is obstructing the system. So how we're going to know if there's an obstruction is you're going to look at the water seal, and the water seal should be going back and forth with each breath. That's called titling. It should be titling with each breath. If it's not, you have an obstruction somewhere. If we see an obstruction in the tubing, or we think there's a clot there in the tubing, we don't want to strip the tubing. Stripping means you grip it with two hands and you grip it hard, and then you pull the tubing. This generates a very high negative pressure within the tube, which can cause the patient to have barrel trauma. Report drainage that's more than 100 an hour. Well, it may be initially that you have drainage more than 100 an hour, but that should start to taper off pretty quick. Keep the tubing free of obstruction, and use this acronym here, STOP, to help you with your assessment. We're going to assess the site and make sure that dressing is intact, that there's not a lot of drainage around the dressing. We're not hearing air moving in around the dressing. Assess the tube itself. Is the tube in good shape? It's not underneath the patient. It's not kinked. Look at our output. What does our output look like? Is it consistent? So if we had clear output last shift, we'd expect to see clear output again this shift. And then lastly, we want to make sure that our system is patent. And as I already mentioned to you, we check that by looking at the water seal. If the water seal is moving back and forth, then we know that our system is patent. Some problems that can occur with our chest drainage system is a tension pneumothorax. So if that system becomes kinked, then the air can start building up again inside that pleural space and actually cause a tension pneumothorax. If we have sudden increases or decreases in drainage, increase could mean that maybe a bleeder broke free. Decrease in drainage could mean that we have a kinked tube somewhere or we have an obstruction somewhere. The system fell over. Where first thing you want to do is pick it up. Okay? Pick it up. It may still be working. If it's still working, we can probably just continue to use it. If something is not working in the system, then we'll want to get another one. But pick it up, and hopefully we still have our water seal intact so that the patient is not getting air moving back into their pleural space. Patient transfer, well, we can disconnect it from the suction. Remember, the suction is just additional. We need to have an intact water seal in order to reinflate the lung, but the suction just makes it happen faster. So you can disconnect from suction to move the patient from one place to another. As soon as you get them there, you put them back on suction. Specimen collection. We want to collect our specimens out of the tubing and not out of the collection chamber. That collection chamber has been sitting there a while, and it's growing stuff, and all sorts of other things are going on down there. So if you need a specimen, you want to collect it out of the tubing. Our water level has changed. We'll add more water. Clots in the system. You want to try and milk those. Milking is just kind of squeezing above the clot to slide it down the tubing. We're not grabbing the tubing and yanking on it, stretching it between our hands in order to create that high pressure. If we have to replace the system, this is one of those times when you're going to clamp the tube. We've all been taught, never clamp the tube, right? Well, if you have to replace the system and you disconnect the tube from the system, air is going to rush into the pleural space. So we will get our system ready, completely ready. Okay, don't disconnect the old one. The old one's still in place. We get our whole new system ready. We clamp, pull out of the old one, push into the new one, unclamp. What is that? 3 seconds. Chest tube removal. Well, we have the lung that's re-expanded. That's what we're going to be looking for, is re-expansion. We want to prep for removal by clamping for 2 hours. Okay, this is another one of the situations where we may clamp, because we want to see that there's not going to be a reemergence of this pneumothorax or hemothorax, whatever the case may be. We want to make sure that it's not going to reoccur if we pull that tube out. So for about 24 hours after we pull the tube, we want to put an occlusive dressing on. Therefore, afterwards, we can just use a dry, sterile dressing. That's no problem. Our properly functioning chest drainage system, we should see gentle bubbling in the suction chamber. Okay. We shouldn't see anything looking like what's on the left, okay? So it shouldn't look like a tidal wave. We should see gentle bubbling in the suction chamber, no bubbling in the water seal. If we have bubbling in the water seal, it means we're pulling air out of the patient. Well, now we'd expect that at first, right? So when you first hook up this chest drainage system, we would expect to see bubbling in the water seal because we are pulling air out of the patient. However, now it's day 3, and I'm looking at that water seal, and I'm seeing bubbling. That's telling me I still have an air leak somewhere. Maybe the air leak's in the lung. Maybe the air leak's around my dressing. But there's still an air leak that is allowing air to get into the pleural space. Gentle rising and falling of water in the water seal. We'd expect to see that with respiration. So it moves with respiration because of the pressure changes in the thorax. To learn more about properly functioning chest drainage, see our video here at bit.ly/chest_drainage. Well, thank you for joining me for Respiratory Part 2. You're doing great here. Keep going. Remember, if you have questions as we go through this, reach out. You're never alone in this review.